Today, advanced percutaneous spinal interventions can achieve the total, immediate neutralization of incredibly complex disease states in a single, minimally invasive clinical session. Advancements in image guidance and mechanical hardware are irrelevant if the biological timing of the intervention is ignored. Vertebroplasty serves as the baseline for stabilization. We inject polymethyl methacrylate cement directly into the damaged vertebral body to provide immediate structural support. Advanced percutaneous architectures take this further. Mechanical implants like the spine jack can actively restore the height of a collapsed vertebra before the cement stabilizes the repair. The apex of the field pairs this structural augmentation with targeted tumor ablation. 2 radiofrequency probes are placed into the bone to burn away metastatic tissue. Clinical success requires matching these percutaneous mechanics to the specific histological state of the target, whether navigating an osteoporotic fracture timeline or a metastatic tumor microenvironment. The primary driver of clinical yield in modern radiology is biological target optimization. Early randomized controlled trials, such as the Bookbinder and Calm studies, dismissed vertebroplasty, suggesting it offered no more benefit than a sham surgery. This table breaks down the parameters of 4 major trials to isolate the specific variable that caused those early failures. The Bookbinder and Calms trials targeted patients with a mean fracture age between 12 and 18 weeks. At 12 to 18 weeks, a fracture has entered the subacute or chronic phase, which severely alters the internal structure of the bone. The Vapor trial, however, strictly intervened during the acute phase. The average fracture was just 2.6 weeks old. Correcting the intervention timeline led to a significant 44% improvement in pain reduction at 2 weeks. In earlier trials, there was no measurable difference from a placebo. The cement and delivery hardware functioned correctly in the early trials. The biological timing was the point of failure. This diagram visualizes the microenvironment of an acute fracture under 3 weeks old. It consists of loose trabecular microfractures and wide, low-resistance cavities. Severe pain in this phase is driven by dynamic instability, which occurs when the vertebra compresses during upright posture. The lack of internal resistance during this acute window allows PMMA cement to flow easily. It interdigitates with the cancellous bone and arrests the movement causing the pain. After 6 weeks, internal fracture conditions change. On the right, reparative bone formation and dense osteosclerosis create thick walls that physically close off internal pathways. This chronic density causes injected cement to hit a mechanical wall. Distribution is limited, and the risk of extravasation increases. Advanced hardware can only overcome structural collapse if the biological resistance of the bone allows for deployment. By respecting the biological window, clinicians leverage the absence of osteosclerosis to achieve stability. In cases of metastatic disease, clinicians face the dual threat of an aggressive tumor burden and severe mechanical instability within the delicate spinal architecture. Standard external beam radiotherapy fails to provide pain relief for 30% of patients and increases the risk of subsequent vertebral fractures. The modern solution pairs targeted thermal ablation to neutralize the tumor with immediate cement augmentation. Bipolar radiofrequency ablation requires the precise bipedicular placement of 2 probes, separated by exactly 1 to 2 centimeters. This probe spacing creates a closed electrical circuit. The current creates a consistent elliptical destruction zone at 70 degrees Celsius, cavitating the tumor between the probe tips. This closed circuit design prevents thermal energy from escaping toward the spinal cord. Alternatively, cryoablation uses targeted freezing to form intracellular ice crystals that rupture tumor cell membranes. Thermal ablation neutralizes the local tumor microenvironment, providing palliation that radiotherapy alone often cannot achieve. There is a significant safety discrepancy between radiofrequency heat and cryoablation freezing when working near the spinal canal. Intact cortical bone naturally insulates against radiofrequency heat, keeping the energy contained within the vertebra. However, cortical bone does not insulate against an advancing ice ball, requiring exact spatial monitoring. An active and continuous biological defense system naturally further protects the vulnerable neural elements from any escaping thermal heat. This is the heat sink effect, where the continuous circulation of cerebrospinal fluid absorbs and dissipates localized thermal energy. Thermally destroying and cavitating the tumor leaves behind the specific physical void required for cement injection. The active destruction of the tumor microenvironment is the prerequisite for stabilizing the compromised spine. Minimally invasive spinal interventions offer lower morbidity and mortality than open surgery, but their success depends on nonlinear factors. Precise needle gauges and titanium expansion ratios provide the means for access, but they do not guarantee clinical success. Ultimately, long-term clinical success with these advanced procedures depends entirely on mastering the target's underlying biological state and timing. For osteoporotic fractures, this means intercepting the microfracture before osteosclerosis physically locks the deformity. For oncology, it means pairing aggressive thermal cavitation with immediate structural augmentation. When the biological environment is optimized, the hardware and cement fill achieve their maximum potential. Interventional radiology has evolved into a field defined by biological synergy.